Good afternoon, dear students. And today we will continue to discuss fecal-oral route of transmission infectional diseases. And the most typical and the most widespread representative of these diseases is salmonellosis. So this lecture is dedicated to salmonellosis. After this lecture, you will be able to describe the Salmonella nomenclature system, describe the epidemiology of non-typhoidal salmonellosis, explain the path of physiology and clinical manifestation of non-typhoidal salmonellosis, and you will be able to confirm diagnosis of salmonellosis and to know main principles of management and prevention of non-typhoidal salmonellosis. So, salmonellosis is the main cause, the cause of disease of is Salmonella, and Salmonella is a widespread spectrum bacteria with Enterobacteria family, genus Salmonella. Agents are highly adapted for growth in both humans and animals. And according to the classification of Salmonella, there are different serotypes of Salmonella. And these serotypes usually divided to two groups, like Salmonella typhi and paratyphi, is usually have a human host and usually cause disease called typhoid fever, and the rest of serotypes are called non-typhoidal salmonella, or the abbreviature is NTS, and can colonize the gastrointestinal tract of a broad range of animals, including mammals, reptiles, birds, and insects. There are more than 200 serotypes are pathogenic for humans and animals. And usually these serotypes can be associated with localized infections or bacteremia. Here you can see the different serogroups and serotypes example of Salmonella, of non-typhoidal Salmonella. As you see, there are 4 main serogroups. They are A, B, C, and D groups of non-typhoidal Salmonella. And the most typical and the most widespread non-typhoidal Salmonella are Salmonella Newport, Salmonella enteritis, Salmonella Dublin, and etc. And these non-typhoidal salmonellas are usually the main cause of Salmonella gastroenteritis, and sometimes it usually caused bacteremia, so generalization as a process could happen. So non-typhoidal salmonella typically cause gastroenteritis, and it was estimated that about 94 million cases, foodborne cases, are caused by non-typhoidal salmonella, usually due to generalization of the clinical process, and usually caused to bacteremia, could lead to deaths. And you see that there are about 155,000 deaths yearly estimated that are due to non-typhoidal salmonella. The most commonly identified serotypes of foodborne salmonellosis are, as I said already, Salmonella enteritis, Salmonella Newport, Typhimurium, and Salmonella infantis. So Salmonella infection represents a considerable burden in both developing and developed countries. Effort to reduce transmission of Salmonella by food and other routes must be implemented in a global scale. You see that Salmonella is a rather hardy bacteria, and it could survive several weeks in a dry environment and several months in the water. But Salmonella could be killed by boiling, chlorination, and pasteurization, mostly at once. Non-typhoidal salmonellosis is intestinal infection with fecal-oral route of transmission, and primary modes of transmission include foodborne and animal contact. Less commonly, it could happen person-to-person transmission. There are multiple animals reservoirs for non-typhoidal salmonellas. So you see the most typical products that could be infected with salmonella are eggs, poultry, undercooked ground meat, dairy products, and fresh produce contaminated with animal waste. So centralization of food processing and widespread food distribution have contributed to the increased incidence of non-typhoidal salmonellosis in developed countries. On this slide, you also see that the most typical foods that was associated with salmonella outbreak are poultry and eggs and pork. But so this food obviously should be well done, should be well cooked. But not only food could be contaminated with salmonella, but also other animals like amphibians, like African hedgehogs, birds, rodents, dogs and cats also could be infected with non-typhoidal salmonella and could be the source of infection for the persons. But there are some host and bacteria factors that predispose to severe salmonella infection and could be predisposed to increase susceptibility of salmonella infection. As you see, the main host factor that increase susceptibility to salmonella infection is age. And typically neonates that are younger than 12 months and elderly people more than 50 years old people typically have the higher rates of severe salmonella infection. Also, the persons with the immunosuppression and immunodeficiency also could have a high could have higher susceptibility to salmonella infection, and usually bacteremia happen for these persons. So the persons with non-controlled or not tolerated to RT HIV infected persons, also the patients with organ transplantations and who are on corticosteroid therapy usually have a high risk of bacteremia to salmonella and severe disease of salmonellosis. The main causes of phagocytic function of the human body, like hemoglobinopathies, chronic granulomatous disease, Bartonellosis, malaria, disseminated histoplasmosis, and schistosomiasis, also could lead to severe salmonella infection after its infection. Those status that lead to lower acid resistance to low and lower gastric acidity, like antacids or suppression of acid secretions, and such status like achlorhydria also could lead to high colonization of Salmonella in the human tract and also could lead to severe disease. And as well as intestinal flora and mucosal integrity factors could lead to severe salmonellosis. So those persons who have very often antibacterial treatment in the clinical course of other diseases, either bowel surgery or inflammatory bowel disease or a gastrointestinal malignancy, also could have severe salmonellosis due to bacteremia. Speaking about bacterial factor of salmonellosis, you see that the main is ingested dose of Salmonella. So the higher doses, the high ingested doses of Salmonella could lead to severe infection. But Salmonella also have other additional factors like pathogenicity islands, virulence of Salmonella, and surface molecules like hemolysins. So these are the Salmonella pathogenicity factors. In contrast to enteric fevers, non-typhoidal Salmonella gastroenteritis, this is characterized by massive polymorphonuclear leukocyte infiltration into both the large and small bowel mucosa. It could lead to immunity response to this infiltration and induction of interleukin-8 production, a strong neutrophil chemotactic factor which is secreted by intestinal cell as a result of Salmonella colonization and translocation of bacterial proteins into host cell cytoplasm. The degranulation and release of toxic substances by neutrophils may result in damage to the intestinal mucosa, causing inflammatory diarrhea, observed with non-typhoidal gastroenteritis. It also could lead Salmonella colonization also could lead to osmotic diarrhea as well. Here you can see the main clinical forms of non-typhoidal Salmonella, and as you see, the most typical clinical form of Salmonella is Salmonella enteritis. But due to generalization of infectional process, it could happen Salmonella sepsis and other localized Salmonella infections due to Salmonella sepsis as well, like Salmonella arthritis, meningitis, osteomyelitis, pneumonia, and renal tubulointestinal diseases. You see that the main incubation period of Salmonella gastroenteritis is about 6 to 24 hours. The minimum incubation period is usually 2 hours and the maximum is 72 hours. And typically the incubation period demands on the dosage ingested of Salmonella. Sorry, incubation. So you see that it is a very short incubation period is typical for Salmonella gastroenteritis. And this disease usually have acute, sudden onset, rapid course on disease, and usually last from 2 to 7th day. And typically, Salmonella gastroenteritis is self-limited disease. Typically, diarrhea resolves within 3 to 7 days, and fever usually resolves in a couple days, in 1 or 2 days of disease. The other symptoms that could happen with the patient is a stomach ache. Preferably, it's around the nail and in the right lower area abdomen. The other symptom that is typically for Salmonella gastroenteritis is diarrhea, vomiting, and nausea. Diarrhea usually have a liquid stool of greenish color. Diarrhea, nausea, and vomiting sometimes could lead to dehydration and severe complications that are connected with dehydration. Symptoms are relatively mild and patients recover without specific treatment in most cases. In the young and the elderly patients with weakened immunity, salmonellosis is associated with severe clinical course with dehydration and life-threatening condition. So, and now we will talk about dehydration. As you know, according World Health Organization classification, there are 3 stages of dehydration. They are mild, moderate, and severe. How can we distinguish all these stages? It will be and it will help us patients examination. So we should estimate patient's mental status, thickness of ears and mucosa of mouth and tongue, patient's thirst, and we should estimate whether patient have tears. So you see that in mild hypovolemia, patient usually is alert, his eyes are normal, there are tears in patients, and the patient's mucosa of mouth and tongue are moist or sometimes slightly dry, and increased thirst. But in case of severe hypovolemia, the patient is usually lethargic or unconscious. He has very sunken and dry eyes, no tears, very dry mouth and tongues, and he drinks poorly or not able to drink at all. Also, we should estimate patient's skin pinch and pulse. And you see that in severe hypovolemia, the pulse is very fast, weak, or non-palpable. It also could be estimated blood pressure that is very low in severe hypovolemia, in severe hypovolemia and dehydration. And also the complications that are connected with dehydration is dehydrative shock and acute renal failure are the most typical complication for Salmonella gastroenteritis. But it could lead to gastroenteritis could lead to bacteremia in some groups of patients that we have already discussed about them. For example, patients with immunodeficiency, neonates less than 12 months, or elderly people more than 50 years old. So it could sometimes happen bacteremia and septic shock, and also could lead to cardiovascular complications like endocarditis, pericarditis, valve perforation, and arteritis, central nervous system infection like meningitis, ventriculitis, and abscess, pulmonary complication like pneumonia, abscess, and empyema, septic arthritis or osteomyelitis if it connected with bones and joints. It also could lead to some abscess of spleen, renal, genital abscess, or other soft tissue abscess also could happen. The diagnosis of non-typhoidal salmonellosis is usually consist of clinical history, clinical presentation, epidemiological history, and non-specific laboratory and instrumental tests. It should be estimated. CBC. Usually patients have leukocytosis and left shift and increased ESR. Besides CBC, it should be controlled urine analysis, stool analysis, blood biochemistry. Especially you should pay attention on renal function tests like urea, creatine. Also should be estimated electrolytes level like potassium, sodium, and chlorides, acid-base balance. You should obviously monitor fluid balance for these patients and diuresis, as well as vital monitors, especially in patients with severe hypovolemia. Instrumental methods that should be done is electrocardiogram and ultrasound of abdomen. Speaking about specific diagnosis of salmonellosis is typically should be done stool culture. It's a golden standard for diagnosis of non-typhoidal salmonellosis. Stool culture should be done for all patients with acute diarrhea, including severe illness, in patients with immunocompromised conditions and comorbidities that increase the risk of complication. Speaking about blood culture for salmonellosis, it should be given for all the patients with known or suspected Salmonella gastroenteritis and gastroenteritis with severe course of condition. Frankly speaking, for all patients who are hospitalized with this diagnosis. Especially for patients with endovascular graft or known atherosclerosis and patients less than 12 months or more than 50 years of age. So this is a main risk group for severe salmonellosis. Should be done blood culture, obviously. Speaking about molecular tools, they are highly sensitive, multiplex nucleic and acid amplification tests are commercially available for detection of Salmonella and other enteric pathogens in stool samples. Their clinical utility remains uncertain because since these tests do not provide antimicrobial resistance results. Here you can see the example of diagnosis for Salmonella enteritis. In your diagnosis, you should obviously write about severity of disease, severity of dehydration, and to write where the patient have some complication. In this example, you will see that the patient have dehydration shock and acute renal failure, and the classification of acute renal failure with Akin stages. Speaking about treatment of Salmonella enteritis, the first place that you should start at once after onset of diarrhea, vomiting, and nausea is fluid and electrolyte replacement. It also should consist supportive care like gastric lavage, to prescribing of antiresorbents, symptomatic treatment like antiemetics, spasmolytics, and non-steroidal anti-inflammatory drugs. Frankly speaking, routine antimicrobial therapy is not recommended for mild or moderate cases. This is because antimicrobials may not completely eliminate the bacteria and may select for resistant strains, which subsequently can lead to the drug becoming ineffective. And antibacterial treatment is usually should be prescribed for patients with severe illness and for the treatment of patients at high risk for invasive disease. Who are they? Who are these patients? So, severe illness patients are those patients with severe diarrhea, more than 10 stools per day, and also high persistent fever. Also, could be severe illness. So, and all the patients that need to be hospitalized. Speaking about high risk for invasive diseases, as we already told about, they are infants less than 12 months of age and adults more than 50 years of age, especially those adult persons with known atherosclerotic disease are at high risk of endovascular infection and arthritis and arteritis when bacteremia develops. Those with endovascular or osseous prothesis may also reasonably be considered to have a similar risk of metastatic infection and warrant antibiotic therapy, even if not severe ill with gastroenteritis. The other group of patients with high risk of invasive disease are the patients with poorly controlled HIV infection and other immunosuppression, like organ transplant recipients, patients receiving corticosteroid or other immunosuppressive agent due to other diseases, concomitant diseases, patients with cancer or lymphoproliferative disease with current or recent chemotherapy. Also patients with sickle cell disease or other hemoglobinopathies, and patients with diseases of reticular endothelial system, including cirrhosis. Also, patients with endovascular abnormalities or implanted prosthesis material, like patients with atherosclerotic diseases, prosthetic heart valves, and prosthetic joints. What is empiric antibiotic selection? Typically, if the patient have no any contraindication, we should start antibacterial treatment with fluoroquinolones when we suspect non-typhoidal Salmonella gastroenteritis, severe illness, or for those people who have a high risk of severe disease. We could start with ciprofloxacin or levofloxacin. These fluoroquinolones are the treatment of choice because of their activity against most common gram-negative enteric pathogens, their high tissue and intracellular concentration, and their favorable side effects profile. Alternative oral antibiotics agents include trimethoprim sulfamethoxazole, cefixime, and azithromycin or amoxicillin. It's an oral antibacterial treatment, but in severe cases, in bacteremia, could be prescribed parenteral empiric antibacterial therapy. So it could also be intravenous fluoroquinolones or third-generation cephalosporins like ceftriaxone or cefixime. The duration of antibacterial treatment is usually lasts from 3 to 7 days in immunocompetent individuals. But for patients who are treated because of age or underlying vascular disease or the presence of implanted prosthesis devices, the optimal duration is uncertain. Most experts would recommend from 3 to 14 days of treatment depending upon the specific clinical situation, suspicion for bacteremia, some laboratory findings, and microbiological data. I should notice that it is prudent to limit antibiotic exposure for all the patients with non-typhoidal salmonellosis because antibiotic treatment has potential to paradoxically prolong carriage, and there are risk of adverse drug reactions and antibacterial resistance. And now we will talk about rehydration treatment, because always we should start with rehydration treatment for all the patients with diarrheal syndrome. So it could be divided on two main groups, like oral rehydration treatment or intravenous rehydration treatment, and it usually depends on patient's condition. You see that intravenous fluid replacement should be prescribed for severe dehydrated patients, the patients with vomiting independently on stage of dehydration, and for diabetic patients. And speaking about oral rehydrative treatment, it should be prescribed for all the patients with mild or moderate severe dehydration, and if the patient have no vomiting. Here you can see the electrolyte electrolytes composition of oral rehydrative solutions that are recommended with World Health Organization. So you should know that these electrolyte solutions should be with low osmolarity and should contain potassium, sodium, chloride, citrate, and obviously should contain glucose. Speaking about oral rehydrative solution, so you see that none of commonly used beverages that could be used for your rehydration therapy is not good for rehydrative treatment. Neither apple juice, no chicken broth, no some teas, nothing, because all these beverages have not any sufficient electrolyte containers, and typically these beverages are with high osmolarity, but we need low osmolarity for rehydrative treatment. Frankly speaking, rehydration therapy should contain should start with primary rehydration, and total fluid deficit should be replaced safely within first 4 hours. Half of this volume should be given with the first hour after the starting of primary rehydration. Also, you see the method how to calculate in different stages dehydration. So it's about from 30 to 40 milliliter per kilogram in mild dehydration, 50 to 90 milliliter per kilogram in moderate dehydration, and more than 100 milliliter per kilogram in severe dehydration. If your patient have hypovolemia due to vomiting and diarrhea, you also could use this algorithm that The first that you should estimate, that the physician should estimate, whether the patient is hypovolemic. So if the patient have two or more of the following signs like sunken eyes, absence of tears, dry mouth and tongue, thirst, and decreased skin turgor, then he is estimated like the patient with hypovolemia. If the patient have no any of these signs or maybe one of these signs, then the patient have no any hypovolemia. But if the patient continue having diarrhea or vomiting, then this patient should be reassessed regularly during the first 6 hours of his examination. And also this patient should be given oral rehydrative solution after each stool or up to 2 liters per day. But if the patient is hypovolemic, then we should estimate the stage of hypovolemia. So if the patient have lethargy or unconscious or inability to drink or weak radial pulse, then the patient have severe hypovolemia. If there are no any of these signs, then it's some hypovolemia. For patients with some hypovolemia or moderate hypovolemia, should be given 2.2 to 4 liters of oral rehydrative solutions in the first 4 hours after the beginning of dehydrative treatment. And this patient obviously should be reassessed regularly during the first 6 hours. But in severe hypovolemia, patient should be hospitalized immediately. It should be prescribed intravenous rehydrative treatment. It should be given for rehydration Ringer's lactate or normal saline, and it start repeatedly about 30 milliliter per kilogram during the first 30 minutes. Then it should be slowed down. The main goal for the treatment for this treatment is about 2 milliliter per kilogram over 24 hours, with 100 milliliter per kilogram should be given in the first 4 hours. And obviously, this patient's condition should be reassessed every 6 hours, obviously. Speaking about prevention of non-typhoidal salmonella, there are no specific preventive measures for this disease, but we should pay attention for reducing of bacterial contamination and animal-derived food products. We should improve food safety education and training. We should monitor every step of food production, and food should be eaten after pasteurization, irradiation, or proper cooking. And obviously, we don't forget about routine hygienic measures that also should prevent contact mode of transmission. So, dear students, now we will stop to discuss about salmonellosis and about non-typhoidal salmonella enteritis, and I hope that you get the remember and you know that there are two main serotypes of salmonella, like salmonella typhi and non-typhoidal salmonellas. And typically, non-typhoidal salmonellas usually caused Salmonella enteritis. The primary modes of transmission for Salmonella enteritis are foodborne and animal contact. The main symptoms of Salmonella enteritis is usually include diarrhea, nausea, vomiting, fever, abdominal cramping, and stomach ache. The incubation period of Salmonella gastroenteritis is very short and last about from 2 to 72 hours, and typically Salmonella gastroenteritis is self-limited diseases. Definitive diagnosis required isolation of Salmonella from stool culture or blood culture if we suspect bacteremia. Fluid and electrolyte replacement, supportive care as a typical method of treatment for most of moderate and mild Salmonella gastroenteritis. And routine antibacterial treatment should not be prescribed for this patient. It should be given only for special groups of patients. And you should know that nowadays there are no non-specific prevention. See you, dear students, in our practical classes. Thank you for your attention and goodbye.